Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today I'm actually going to take a little departure from the specialties I normally talk about and the compliance risks I talk about, well, everything I talk about, and actually mention couple of little things about behavioral health. It's been something I've been diving into over the last couple of years, and my audits seem to be heavy with behavioral health. I know my membership clients always seem to have behavioral health questions. And so just over the last little while, I've been really I don't want to just say diving into it, but because it's actually not my favorite topic because there's so much ambiguity, there's so many gray areas. And fortunately, the payers are now really recognizing that specialty as a payable specialty. I've been in, healthcare so long. Back in the day, 80s and 90s, they did not pay for that, and you had to do everything you could to stay away from the 300 codes when you had ICD-9. But now that we get into some of the mental health situations and just some of the screenings and all that, it seems to be much more amenable to payers to really reimburse a lot of the behavioral health services. But the unfortunate part now is I see a lot of overdiagnosing just to get the service paid, or labeling patients as, a potential mental health disorder when they don't really have one. And, I've seen more and more providers get in trouble for pushing the envelope a little bit too far. And then there's also some things that cross over where they are not considered incident to, and I'm air quoting, or they have to be done by a provider that has a certain skill to evaluate certain services. So, let's talk about that just a little bit. And this isn't going to be a long podcast today because I just wanted to really refer to some questions that came up during a webinar I was listening to, and then another one that I was just looking at the follow-up questions, and I thought, well, that's interesting because I may have responded to it a little bit different. So a question came in, and it said, Terry, I listened to a webinar yesterday, and they said that the NP, nurse practitioner, had to be credentialed and or licensed within an insurance company to be able to bill for behavioral health services. And I've asked them several times in follow-up if this is true, but I haven't gotten a response. So I know which webinar they were talking about. And, every provider does have to be credentialed with payers unless the payer specifically does not enroll a specific provider type. And you'd have to find that within your contract. The only major payer that I'm aware of that does not credential mid-level providers is Cigna. So credentialing is required. Never try to get out of it with Medicare or Medicaid. And really look at the contract language before you hire a mid-level provider, and make sure that if that's something that you're planning on doing, make sure that they are covered when they bill independently, because you're not always going to meet the criteria of having a provider and a physician in the office if you're looking at incident to, and you're not always going to meet the criteria of that payer possibly reimbursing if they're the ones that are billing direct. And you also have to make sure that what your fee schedule is, because as you know, with Medicare, if they bill direct, you take a 15% haircut, and it's about 85% reimbursement. And, I'm not saying that's a bad thing. I'm saying for someone who's not an MD or DO, that's a great reimbursement. But you need to know what you're looking at if it's billed directly. Also, I want to apologize. I have a new outside dog neighbor that seems to want to bark today. So I apologize for that the day that I am recording. That never happens. So the other question says, the NPs do education visits with patients on their first treatment day. They go over the treatment plan, what to expect, what to look for, and how to handle the side effects. These visits are done on time for the most part, because of the time preparing the booklet for the patient with all of the needed documentation and the length of time counseling the patient and family. The practice bills this visit with a 25 modifier. Our office disagrees with this being able to be even a billable service. The entire visit is going over the treatment that the patient is receiving that day. So is the 25 modifier even appropriate? It seems to be just helpful for the patient, not really a medically necessary service. So here is my professional opinion on this one. And this one is, probably not going to be popular, but if that treatment plan was previously decided upon, then this is not a billable service. There is pre and post work associated with treatments when patients have a scheduled treatment that they're coming in for, a scheduled procedure. Even when billing based on time, the note must support medical necessity. A couple of podcasts ago, I said medical necessity first and then coding. So you have to support medical necessity for treatment beyond what was previously implemented. And then all procedures, minor or major, have, again, that pre and post-op work included in their value, in their RVU. So for me, that's not medically necessary, and an audit flag if that's just part of your workflow. It's very nice that you do that, but it's just part of the workflow. Hand the patient a booklet before they come in. I mean, they can also, read through it as well. So the next one, same clinic. The clinic has decided to bill for psychological testing, code 96130. They're trying to bill it incident to the provider, the physician. And I want to make sure I'm giving the correct information. I don't think they can do that. So remember what 96130 says. It's psychological testing evaluation services by a physician or other qualified healthcare professional, including integration of patient data, interpretation of standardized test results and clinical data, clinical decision-making, treatment planning and report, and interactive feedback to the patient, family members, or caregivers when performed, and it's a time-based code, first hour. And then you have a 96132, neuropsychological testing and evaluation services as well. And that's very similar, but it also includes the neurophysical part of it as well. So this is an interesting code, and it took some research to figure this out. And I'm going on Medicare guidelines. So Medicare says CPT code 96130, which represents psychological testing evaluation services, physician or QHP generally cannot be billed incident to. It requires a high level of clinical judgment and interpretation. And what that means is the performing clinician must be considered a qualified healthcare professional who can independently bill for the service, not just under the supervision of physician. Therefore, direct billing to the payer is typically required. Now, Medicare always puts things as generally not or generally cannot, and direct billings typically, meaning there may be in some dark corner an exception to the rule, but you have to really understand when you're getting into behavioral health and mental health services, you can't just say I'm a mid-level provider or an MP or PA and I know what I'm doing. It's not the same as a physician. A physician, especially primary care, MD or DO, they actually take courses and, in their residency and in school that focus on the psychological needs of patients, on behavioral health services. NPs and PAs do not. So they would actually have to take an additional course, additional classes, additional certification programs to reflect that they have that high level of clinical judgment and interpretation, in my opinion. So I think that you could be opening up a can of worms there saying that they're going to just be, quote unquote, trained by the provider and then be able to say, I know what I'm doing. It's like I play one on TV. Yeah, let's not do that. So, when Medicare comes out and says this is not billed generally as incident to, they're saying just try it and we're going to come and get you. So they're giving you a hint to, not open up that can of worms, or you could be subject to a problem. And it's not just that code, it's behavioral health services in general. So, when we look at these charts, I'm noticing that whenever I am auditing behavioral health services, they are missing more than the actual medical clinical services that are a little different. I'm noticing some of the client information, name, date of birth, the identifier of the patient. I'm missing the, documentation date, the start and end time, and the type of service provided. The clinical content. What problem are you addressing? If you're billing E&M, you still have to, have a problem addressed. But if you're also billing some of the behavioral health codes specifically, what interventions did you use? Client response. What are the treatment goals and that progress toward treatment goals? And then clearly identify those goals and objectives in the treatment plan to show the connection to the treatment plan from what was addressed at the beginning. And then plan of care outlines next steps or adjustments to the treatment plan, and clear authentication of records. So who is the provider, name, credentials, signature, and all that. But every session needs to count, especially, and I hate to say especially in behavioral health. It's every encounter, but behavioral health is under scrutiny because, again, there's so much now reimbursement for it, whether it be screening, whether it be diagnostic, or whether it be treatment. And if you are in that space, you need to make sure that you are above board and can, support anything you do. And I'm not always seeing that in behavioral health services. And it's interesting because whenever someone asks for an audit, that is something separate. If they come to me and my team is going to audit a practice and they have a carve out. So we have a couple of big clients, in my business. And they have a carve out a couple of specialists in behavioral health. That's the only thing that I say, okay, I do that because it's under different HIPAA protocols. So I don't let my staff into those services. And it's just, that's where I'm responsible. And I want to make sure that if I'm responsible, so is the provider, to make sure things are very tightened up, very protected, but also very well documented so that you're above scrutiny and there's never really reason to have it questioned. And if it is, you can support it and, hold your head up high and not worry about that. And actually, it's funny because that was just that part I wanted to talk about, but there's something that's going on right now with a couple of the payers that use third party like Optum or, certain third party companies to do audits, especially the RAC audits. I'm noticing that, let's say you get a RAC audit and they're saying that, you build a code 99222 instead of or you build a code 99204, let's say a level 4 office visit, new patient, instead of an initial hospital, 99222. And this is a real situation that happened with a client of mine. And he was told, and he said, is this right? So I looked at it and I said, actually, the hospital put in that the patient was inpatient, not even observation. He thought the patient was outpatient. And so he billed appropriately based on what he thought. So the Optum said, well, as long as you agree with what we said, you don't have to respond and we'll just, take back the money. I said, no, you need to respond and say they still owe you, but you just had the wrong CPT code category because you were under the impression that it was a different place of service when you saw the patient, and the hospital place of service designation was not, fully visible. You were not aware, and so they still have to pay you. If you tell Optum or any of these RAC auditors that you are, going to ignore it and not respond to it, that follows you everywhere. So you still have to go into the portal they give you. You still need to respond. Let them know your position. Even if the code that they're saying it should have been was correct, you need to respond why it wasn't sent out that way at the beginning, and send a corrected claim so that you still get, paid. They can take back whatever they think they paid you on the 99204, but then they should refund you, or I should say reprocess your claim for the 99222 as a corrected claim. So please don't ignore those requests, even if they may be correct on their end and you figured it out, after the fact. But I was very disheartened to hear them telling providers to ignore it. Do not ignore it. That could just open up a whole can of worms for you. Whether you agree with it or not, or think it's expensive to, go back to just try and get one service paid, it's more about principle and, having a track record of reviewing it, reading it, not ignoring it, and addressing a problem that's brought to your attention. And that in the long term will definitely stem better for you. So I just want to put that out there because when I see that, it makes me crazy. I'm just like, what are you telling doctors to do? That's really crazy. Okay, so that's basically it for today. I know I'm actually recording on Memorial Day weekend, so I wanted to just make it short and sweet for this upcoming Tuesday. I hope everyone had a restful 3-day weekend. I'm working all weekend. My husband decided to go visit our kids in Arizona, go to a baseball game with them, go golfing. But it's too hot for me now there. Once it gets over 100, I'm like, no, I'll stay in my warm weather, California, do some work over the weekend, nice quiet house, and have some pool time, which is really nice for me to be able to do that. So everyone, again, I hope you're having a great weekend. Thank you for listening. Make it a great day. And thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.